The title of this talk is Nerve and Muscles of the Lower Extremity. These are the class objectives. You do not need to read them. We will use them to chart our talk. This talk will be conducted in a question and answer format. The first question is: the dorsal ramus contributes to the formation of the lumbosacral plexus. A true, B false. The junction of the dorsal and ventral roots form the spinal nerve. The spinal nerve leaves the spinal canal through the intervertebral foramen. Each spinal nerve divides into a ventral ramus and a dorsal ramus. It is the dorsal and ventral rami of the spinal nerve from L1 to S4 that innervates the lower torso and forms the lumbosacral plexus. The dorsal rami innervates the lower torso, that is the muscles of the lower back, and the ventral rami forms the lumbar plexus. So the answer to this question is B. Next question. All ventral rami that form the lumbosacral plexus have sympathetic, parasympathetic, and somatic fibers. A true, B false. The lumbosacral spine nerve, as we have just mentioned, divides into dorsal and ventral rami. The dorsal rami goes to innervate the back of the torso. The ventral rami form the lumbosacral plexus. It is important to know that not all lumbosacral ventral rami have the same type of fibers. All ventral rami have general sensory and motor somatic fibers. Sympathetic fibers are present in ventral rami of L1 and L2, and parasympathetic fibers are present in the ventral rami of S2, 3, and 4. So the answer to this question is B. Next question. Which of the following muscles is present in the lower torso? A. Multifundus muscle. B. Longissimus muscle. C. Iliocostal muscle. D. All of the above. One of the points you need to know is the name of the motor and cutaneous branches of the dorsal rami that innervate the lower back. So far you have seen this figure. This is a horizontal transverse cut of the lower torso showing the dorsal rami innervated muscles and the cutaneous innervation of the same region. In this frame, you can see a vertical illustration of the same muscles. The multifidus muscle here is uncut, here is cut. Multifidus muscle is the most medial muscle group in the back. Here you can see the uncut longissimus muscle, and here you can see the cut longissimus muscle. Here you can see the uncut iliocostal muscle, and here you can see the cut iliocostal muscle. A cut at the level represented by the green dashed line shown in this frame yields the transverse image we have seen before, which you can see here enlarged. I will use the next few frames to build it from scratch so you can better memorize it. You can see in this new frame the spinal nerve represented by a yellow line. The spinal nerve divides into the dorsal and ventral rami. I am now representing the skin and three muscle masses. The multifundus muscle, which is medial, the longissimus muscle, and the most lateral muscle group, the iliocostal muscle. These muscles are innervated by the medial branch, the intermediary branch, and the lateral branch of the dorsal ramus. The skin is innervated by the lateral cutaneous branch. The reason for the asterisk after the word branch or branches is that some authors use the term ramus instead of the term branch for the offshoots of the ventral ramus. So the answer to this question is D, all of the above. Next question. The lumbosacral plexus of all individuals are constituted by the ventral rami of L1 to S4. A true, B false. You need to know how is the lumbar plexus formed. Now that we have talked about the dorsal rami nerve formation, we are going to talk about the anatomical structure formed by the ventral rami of the spinal nerve of the lumbosacral region, the lumbosacral plexus. This is a representation of nerves of the pelvic region. In this frame, I have removed the solid component of vertebral bodies and disc to show the intracanalicular course of the ventral and dorsal roots. They constitute the cauda equina. As you know, at the merging of the ventral and dorsal roots, the spinal nerves are formed. The spinal nerve exits through the intervertebral orifice or foramina. Here I have indicated the four most rostral spinal nerves, and here the most caudal spinal nerve. Now that we have identified the spinal nerves, I'd like to remind you that it is at the level of the spinal nerve is about to enter the foramina, where posterolateral herniation of the intervertebral disc compresses the spinal nerve. The compression occurs in the spinal nerve numerically corresponding to the lower vertebra. Hence, herniation of the disc between L3 and L4, as indicated by the arrow, compresses the L4 spinal nerve. Herniation of the disc between L4 and L5 compresses L5. Herniation of the disc between L5 and S1 compresses S1. Compression of the spinal nerve produces radicular pain and a spinal nerve muscle weakness pattern. I will now indicate the dorsal rami here of the four most rostral spinal nerves, and here of the most caudal one. In this frame, I have removed the dorsal rami. The dorsal rami do not contribute to the formation of the lumbosacral plexus. Now we will describe the most frequent anatomical configuration of the lumbosacral plexus and say a few words about some of the anatomical variations of this plexus. So we start with the ventral rami of the five lumbar spinal nerves and the first four sacroventral rami. There are at least two major anatomical variations regarding the ventral rami contributing to the formation of the lumbosacral plexus. One variation consists of the lumbosacral plexus having a significant contribution from the lower thoracic ventral rami and very little or none from the lower sacral ventral rami. The other anatomical variation consists of a very strong contribution of the lower sacroventral rami and even from the coccygeal ventral rami, and none or very little from the lower thoracic or higher lumbar ventral rami. We will talk no further about these variations. So the answer to this question is B. Next question. Which of the following nerves is involved in the motor arm of the cremasteric reflex? A. Iliohypogastric nerve. B. Ilioinguinal nerve. C. Genitofemoral nerve. D. Obturator nerve. The ventral rami forming the lumbosacral plexus split into divisions. Again, there are lots of anatomical variations in the formation of the divisions. In this talk, I will describe to you the one most frequently presented in anatomical books that I have read. Let's first look at L1. The rostral division of L1 advances and divides in two branches. The most rostral of the two branches receives fiber from T12 and forms the iliohypogastric nerve. The iliohypogastric nerve supplies cutaneous sensory fibers for the suprapubic region and sensory and motor fibers to two abdominal muscles, the transversus abdominis and the internal oblique muscles. At times, the iliohypogastric nerve is damaged during abdominal surgery. The damage of this nerve manifests by burning and tingling pain in surgical incision site that radiates to the inguinal and suprapubic regions. Next, we will talk about the second nerve arising from the first division of L1, the ilioinguinal nerve. The ilioinguinal nerve is a pure sensory nerve. In women, it supplies sensory innervation to the upper portion of the inner thigh, mons pubis, and lateral aspect of the labia. In men, it supplies the upper portion of the inner thigh, the base of the penis, and the upper part of the scrotum. Continuing with the construction of the lumbosacral plexus diagram, we need to consider the other division of L1 and one of the anterior divisions of L2. You noted that for the first time I have used the term anterior to qualify a division. It is important to do so at this point because most nerves are constituted either from anterior or posterior divisions, and you may be asked about this in your exam. So, as we were saying, one of the anterior divisions of L2 and the caudal division of L1 joint, forming the genitofemoral nerve. This nerve supplies the skin of the lateral femoral triangle, and in women the labia majora, and in men the anterior scrotum, and cremasteric or cremaster muscle. The genitofemoral nerve may be damaged during abdominal laparoscopy surgery. The loss of the motor function of this nerve produces loss of the cremasteric reflex. Now, I like to call your attention to one of the posterior divisions of L2 and a posterior division of L3. They join to form the laterocutaneous nerve of the thigh. Injury to this nerve as it goes under the ilioinguinal ligament produces meralgia paresthetica. Injury to the laterocutaneous nerve of the thigh is usually due to tight clothing, obesity, weight gain, or pregnancy. Meralgia paresthetica is characterized by paresthesia over the lateral surface of the thigh in the area indicated in this illustration. Now let's go back to the diagram and look at the second anterior division of L2, here indicated. Let's also look at the anterior division of L3 and the anterior division of L4. These divisions join together to form the obturator nerve. The obturator nerve provides sensory fibers for the hip articulation and to the medial thigh just below the territory innervated by the ilioinguinal nerve, and sensory and motor fibers for obturator externus, adductor magnus, pectineus, adductor longus, adductor brevis, and gracilis. The obturator nerve is often damaged in pelvic surgery. So the answer to this question is C. Next question. Damage to the dash produces Trendelenburg sign. A. Nerve to the iliopsoas muscle. B. Superior gluteal nerve. C. Femoral nerve. D. Inferior gluteal nerve. I will now go back to the lumbosacral plexus diagram and continue adding components. The second posterior division of L2, a posterior division of L3, and a posterior division of L4 join to form a trunk that gives fibers to the iliopsoas muscle and forms the femoral nerve. The femoral nerve supplies cutaneous sensory fibers to the anterior thigh through the medial and intermediate femoral nerves, and it also provides sensory to the medial leg and foot through the saphenous nerve. The femoral nerve also supplies sensory and motor fibers to the sartorius. The muscle sartorius was called so because it is the muscle most used by tailors when they sit in the position above to mend clothes. Sartorius means tailor in Latin. The femoral nerve also innervates the pectineus. Notice that the pectineus is at times innervated by both the femoral nerve and the obturator nerve, or more often just by the femoral nerve, and rarely by the obturator nerve alone. Now back to building the lumbosacral plexus diagram. One posterior division of L4, of L5, and of S1 come together, forming a branch that gives out a nerve called the superior gluteal nerve. I will indicate in this illustration the muscles innervated by the superior gluteal nerve. These muscles are the gluteus minimus, the gluteus medius, which you can also see in this new drawing. The third muscle innervated by the superior gluteal nerve is the tensor fascia latae. Injury to the superior gluteal nerve is often iatrogenic. It occurs during intramuscular injection to the superomedial gluteal region. Damage to the superior gluteal nerve produces Trendelenburg sign. The Trendelenburg sign is detected while testing gait. As the patient walks, the pelvis tilts because the weight-bearing leg cannot maintain alignment of the pelvis. The damage is contralateral to the side of the hip that drops, as you can see in this drawing. Intramuscular injection to superomedial gluteal region can also produce damage to the sciatic nerve. To avoid these type of injuries, remember to inject the anterolateral region of the buttocks, as indicated in this frame. After the formation of the superior gluteal nerve, a posterior branch of S2 join the three posterior branches of L4, L5, and S1 that form the superior gluteal nerve and give out two intermediate branches. The inferior gluteal nerve, which only supplies the gluteus maximus. The gluteus maximus weakness produces difficulty climbing stairs, rising from sitting position, and loss of hip extension. Injury to the inferior gluteal nerve often occurs with posterior dislocation of the femur head in relation to the acetabulum, as you can see in the CT presented here. You can see that the left femoral head is behind the acetabulum. Compare the left side with the normal side on the right. Injury to the inferior gluteal nerve can also occur after intramuscular injection to the superomedial gluteal region, as we previously mentioned. So the answer to this question is B. Next question. Paresthesia in the indicated area, color blue, is likely to be due to damage of A. Tibial nerve, B. Superficial peroneal nerve, C. Deep peroneal nerve, D. Sciatic nerve. The last intermediary branch of this trunk is for the short head of the biceps femoris. The short head of the biceps femoris is one of the hamstring muscles. After the fibers for the short head of the biceps femoris are given, we will find the common peroneal nerve. The common peroneal nerve divides into the deep peroneal and the superficial peroneal nerves. They are also called fibularis. We will now go through a few important facts about the deep peroneal nerve. The common peroneal nerve divides into the deep peroneal nerve and the superficial peroneal nerve, as we just mentioned. As you can see, the superficial peroneal nerve is caught in this illustration. The first muscle innervated by the deep peroneal nerve is the tibialis anterior, the most powerful dorsiflexor of the foot. When this muscle is weak, the foot drops. And the last muscle innervated by the deep peroneal nerve is the extensor digitorum brevis. It is always good when you're thinking about what to learn about a nerve to learn the first and the last muscles it innervates. The only cutaneous territory of the deep peroneal nerve is the web space between the hallux and the second digit. I have gone back to the diagram to indicate that we are going to say a few words about the superficial peroneal nerve. But let's start by saying that the common peroneal nerve, before dividing into the deep and superior peroneal nerves, gives a branch called the lateral cutaneous nerve of the calf. The lateral cutaneous nerve of the calf innervates the lateral region of the leg and also gives a branch to the articulation of the knee. Shortly after giving the lateral cutaneous nerve of the calf, the common peroneal nerve divides into the deep peroneal nerve, which we have already mentioned, and the superficial nerve, about which we will say a few words in a few minutes. We can see in this illustration that the superficial peroneal nerve innervates two muscles, the peroneal longus and the peroneal brevis. The peroneals evert the foot and help with dorsiflexion. I like to use the term peroneal for these muscles because the E in the word peroneal reminds me that these muscles evert the foot. The terminal branch of the superficial peroneal nerve is a cutaneous branch. This branch soon divides into the medial and lateral cutaneous branches. The cutaneous distribution innervated by the cutaneous branches of the superficial peroneal nerve corresponds to the lower lateral anterior region of the lower leg and the dorsum of the foot, but not the first web space, which, as you know, is innervated by the deep peroneal nerve. So the answer to this question is B. Next question. EMG exam revealed normal short head of the bicep femoris left, attempting dorsiflexion, shown in the photo, no left foot eversion, partially weak inversion. Which nerve is likely to be affected in the left leg? A. Sciatic nerve, B. Superficial peroneal nerve, C. Deep peroneal nerve, C. Common peroneal nerve, D. Tibial nerve. The patient deficit consists of no dorsiflexion, no eversion, and limited inversion of the left foot. The lack of dorsiflexion indicates tibialis anterior weakness. The anterior tibialis is innervated by the deep peroneal nerve. The lack of eversion indicates weakness of the peroneus longus and peroneal brevis. Thus, the superficial peroneal nerve is involved. Partial inversion weakness can be explained by tibialis anterior weakness and normal posterior tibialis strength. I remember that the tibialis invert the foot by remembering the I in tibialis to indicate inversion. So, by matching the first letter of the function of the muscle with the name of the muscle, you can, if you remember one, figure out the other as illustrated here. Going back to the graph, you can see that the deep peroneal and superficial peroneal arise from the posterior division of L4, L5, S1, and S2. Going through the posterior divisions of the sciatic nerve, if the lesion were to be at the posterior division of the ventral rami or at the sciatic nerve, the fibers for the short head of the biceps would have been affected, and in these patients they were not. Before leaving the subject, I would like to stress that S2 often does not contribute to the innervation of foreleg or foot peroneal innervated muscles. So the answer to this question is D. Next question. The tibial component of the sciatic nerve has no contribution from the lumbar anterior divisions of the lumbosacral plexus. A true, B false. I am going back to the chart to emphasize that the fibers from the posterior division of L4, L5, S1, and S2 contribute to the formation of the peroneal component of the sciatic nerve. And to tell you that the fibers from the anterior division of L4, L5, S1, and S2, and also S3, come together to form the tibial component of the sciatic nerve. It is also important to remember that the anterior divisions of L4 and L5 often join before joining the rest of the fibers forming the tibial component of the sciatic nerve. The structure formed by this joining of the L4 and L5 fibers is labeled the lumbosacral trunk. The 5 anterior divisions just mentioned, once together, give off 3 intermediate branches and a terminal branch. The most proximal of the intermediate branches, after receiving fibers from the posterior division of S1 and S2, as illustrated in this frame, become the posterior cutaneous nerve. After the formation of the posterior cutaneous nerve of the thigh, the tibial division of the sciatic nerve advances caudally, giving a branch to innervate the abductor magnus, and then another branch for the hamstring muscles, including fibers to the long head of the biceps femoris. The rest of the fibers go on to form the tibial nerve. Distally, the tibial nerve divides into the medial plantar nerve and the lateral plantar nerve. This nerve innervate all the intrinsic muscles of the foot except for the extensor digitarum brevis pedis that is innervated by the deep peroneal nerve. The area just encircled in this frame is the sciatic nerve, which ends with the formation of the common peroneal nerve and the tibial nerve. So the answer to this question is B. Next question. Which of the following muscles is often innervated by the obturator and the sciatic nerve? A. Vastus lateralis. B. Semimembranous. C. Semitendinous. D. Abductor magnus. E. Biceps femoris, short head. This is a very complicated drawing of the branches of the sciatic nerve. I will use this drawing at this point to highlight the muscles of the sciatic nerve prior to the sciatic nerve splitting into the tibial nerve and the peroneal nerve. These muscles are the abductor magnus, that is also innervated by the obturator, the semimembranous, semitendinous, and biceps femoris long head. Notice that the short head of the biceps femoris is innervated by the peroneal fibers. These 3 muscles just highlighted constitute the hamstring muscles. The spinal nerves forming the sciatic nerve are often involved in this herniation. The sciatic nerve trunk is often involved with posterior hip dislocation and injections in the superior medial gluteal region. So the answer to this question is D. Next question. Most authorities regard the sural nerve as forming from the terminal branches of the tibial and common peroneal nerves. A true, B false. This is the same illustration you saw before. I'd like to call your attention to the sural nerve. The sural nerve in most instances is formed by a sensory branch of the common peroneal nerve and a sensory branch from the tibial nerve. The sural nerve travels behind the lateral malleolus. The cutaneous area innervated by this nerve are the lower lateral leg, lateral heel, lateral ankle, and dorsal lateral aspects of the foot. So the answer to this question is B. Next question. After going horseback riding, a patient complains of paresthesia in the penis. Which nerve is likely to be injured? A. Ilioinguinal nerve, B. Iliohypogastric nerve, C. Pudendal nerve, D. Genitofemoral nerve. Now back to the lumbosacral plexus diagram. One branch of S2, S3, and S4 join, forming the pudendal nerve. The word pudendal comes from the Latin word meaning to be ashamed. The pudendal nerve supplies sensory fibers to certain areas of the mid-perineum. The name of the nerves innervating the skin is different in men and in women. The muscles innervated by this nerve are those of the pelvic floor. The pudendal nerve also supplies sensory and motor fibers to the external urethra and anal sphincter. Injury produces paresthesia and decreased sensation in the perineum and genitalia areas. Injury to the pudendal nerve can also cause fecal incontinence, urinary incontinence, or both. Injury usually occurs during delivery as the maternal pudendal nerve is stretched, prolonged cycling, and horseback riding. So the answer to this question is C. Next question. Which of the following structures carry parasympathetic fibers? A. Nerve to the piriform muscle. B. Lumbar splenic nerve. C. Pelvic nerve. D. Pudendal nerve. As indicated in this frame, from the posterior division of S2, a branch comes out to innervate the piriform muscle. Other branches arising from the lower lumbosacral plexus that medical students have no need to memorize but need to know about are destined to innervate the obturator internus, superior and inferior gemelli, and the quadratus femoris. I have also omitted, for the same reason, the description of a few branches arising from the superior region of the lumbosacral plexus, innervating the quadratus lumborum. This muscle contraction produces lateral flexion of the trunk or raises the hip. Medical students do need to know that L1 and L2 spinal segments have sympathetic neurons and that fibers from these preganglionic neurons form the splenic nerve. Postganglionic neurons innervated by fibers from the splenic nerve provide sympathetic innervation to the kidney, bladder, gonads, uterus, and external genitalia. Medical students also need to know that S2, S3, and S4 spinal segments have parasympathetic neurons, whose fibers, here added to this figure, form the pelvic nerve. The pelvic nerve forms the pelvic plexus. Distal branches from this plexus innervate the distal third of the transverse column, the descending column, the sigmoid column, the rectum, the upper portion of the anal canal, and the uterus. So the answer to this question is C. Next question. Which is the only muscle innervated by the peroneal division of the sciatic nerve in the thigh? A. Vastus lateralis, B. Semimembranous, C. Semitendinous, D. Bicep femoris, long head, E. Bicep femoris, short head. In this frame, you can see the nerves that innervate the muscles of the thigh. From the lumbar region, posterior divisions, we have the femoral nerve, which innervates muscles in the anterior muscle compartment of the thigh. From the anterior divisions, the obturator nerve, which innervates muscles in the posterior muscle compartment of the thigh. From the lumbosacral plexus, we also have anterior divisions from which arise the tibial fibers to the sciatic nerve, which innervate muscles in the posterior muscle compartment of the thigh. And from the posterior division, the only muscle of the thigh innervated by the peroneal nerve, the short head of the bicep femoris. In this frame, you can see the nerve that innervate the muscles of the foreleg. The tibial nerve innervate muscles in the posterior compartment despite arising from the anterior divisions of the ventral rami, whereas the posterior divisions form the peroneal nerve that innervates the anterior foreleg compartment. The muscles of the foot are also innervated by the tibial and peroneal nerves. The anterior division innervates all muscles of the foot except extensor digitorum brevis. This muscle is the only muscle in the dorsal surface of the foot and the only one innervated by the posterior division of the lumbosacral plexus, as shown in this illustration. So the answer to this question is E. Next question. Which of the following muscles is innervated by the anterior division of the lumbosacral plexus? A. Rectus femoris, B. Tibialis anterior, C. Peroneus longus, D. Semimembranous, E. Extensor digitorum brevis. I will use this figure to look at the muscle anatomy of the lower extremity at different sites. These sites are high thigh, middle leg, and a coronal view of the foot. We will start by looking at an illustration of the high thigh. Here you can see a transfer cut at the level of the high thigh. A line through the back of the femur divides this region into anterior and posterior leg compartments. I have now labeled the muscles in the anterior compartment. The muscles in the anterior compartments are the vastus lateralis, intermedius, and medialis, the rectus femoris, the sartorius, and the iliopsoas. These muscles are innervated by the femoral nerve. The iliopsoas is also innervated from similar posterior division fibers as the femoral nerve just prior to the formation of the femoral nerve. The tensor of the fascia latae is innervated by the superior gluteal nerve. As you can recall, this nerve is formed by fibers from the posterior division of the lumbosacral plexus. I have now labeled those muscles behind the blue line. These muscles are considered muscles of the posterior compartment of the thigh, except for the pectineus. Notice that at this level, the pectineus muscle, a femoral innervated muscle, is behind the blue line. Yet, because of its innervation from the femoral nerve, it is considered an anterior compartment muscle. Having looked at the transverse cut of the high thigh, we will take a look at the transverse cut of the middle thigh. You can see in this illustration the muscles of the mid-thigh. The muscles of the thigh at this level can be roughly divided as we did for the high thigh by drawing a line through the back of the femurs as I have done in this frame. Anterior to the line, we find 4 muscles innervated by the femoral nerve. Posterior to the line, in yellow, you can see all the muscles innervated by the sciatic and obturator nerves. They are considered posterior compartment muscles. The only muscle behind the blue line, not in yellow, is the sartorius. This is so because, like the pectineus, at the higher level, despite being anatomically located in the posterior compartment, the sartorius is considered an anterior compartment muscle because of being innervated by the femoral nerve. After the mid-thigh, we're going to look at the middle of the leg or foreleg. In this transverse cut of the foreleg, I have labeled most relevant muscles. I have, as we have done before, drawn a line, but this time through the tibia and fibular to separate those muscles anterior to the line and those muscles posterior to the line. Notice that the tibialis anterior, extensor hallucis longus, extensor digitorum, peroneal or fibularis longus, and peroneal or fibularis brevis are anterior compartment muscles. Notice that unlike in the forearm, the flexors are in the posterior compartment and the extensors are in the anterior compartment. After the middle leg transverse cut, we will look at the coronal view of the foot. In this coronal cut of the foot, rather close to the ankle, I have now drawn a line through the metatarsal bones and separated the muscles above the line from those below the line. This line has the same significance as the line used for higher cuts. It separates muscles innervated from anterior division of the lumbosacral plexus from those innervated by the posterior division of the lumbosacral plexus. The only muscle above the line, and usually the only muscle of the foot innervated by the peroneal nerve, is the extensor digitorum brevis, as we have previously mentioned. All the muscles below the line are innervated by the tibial nerve. In this figure, you can see that the tibial nerve gives a branch called the medial calcaneus nerve that innervates the skin in the area of the calcaneus, in conjunction with the lateral cutaneous nerve, a branch of the sural nerve. Further along, the tibial nerve divides into the medial plantar nerve and the lateral plantar nerve. These nerves innervate all foot muscles except the extensor digitorum brevis, and the cutaneous branches innervate the sole of the foot, including the toes. So the answer to this question is D. Next question. The innervation of the muscles of the anterior compartment of the leg by the posterior division of the lumbosacral plexus is the result of developmental rotation of the lower limbs. A true, B false. As previously stated, muscles innervated by the femoral nerve, a nerve that arises from the posterior division of the lumbosacral plexus, supplies muscle that occupy the anterior compartment of the thigh, whereas the tibial nerve and the obturator nerve that arise from the anterior division of the lumbosacral plexus innervate muscles in the posterior compartment. To understand this arrangement, we must go to embryology. At 6 weeks conceptual age, or just about, the embryo's limbs are extended with the palm and the sole in the same directions as the face. But it is at this time or shortly after that medial rotation of the lower limb starts, as indicated by the circle below corresponding to the left leg at the level of the mid-thigh. The colors of the inside the circle corresponds to the muscles innervated by the different nerves. So muscles innervated by the obturator occupy an anterior lateral position. Sciatic nerve innervated muscles, for the most part corresponding to the tibial nerve innervated muscles, are located in the anterior medial region, and femoral innervated muscles have a posterior position just before rotation starts. In this new frame, corresponding to about 7-week conceptual age fetus, you can see arrows in the fetus indicating the direction of the twist. That, as we initially mentioned, is medial, and the 180 degree by the side of the left arrow, which indicates the degree of twist that the leg will ultimately achieve. Notice the position of each muscle group as compared to the 6 weeks embryo. Notice, for example, the rotation of the femoral innervated muscles. By 9 weeks of conceptual age, the rotation is complete, corresponding to what we find in adults. Similar mechanism is involved in the innervation of foreleg muscles. The tibial nerve arising from the anterior division of the lumbosacral plexus innervates posterior compartment muscles, whereas the fibular nerve, deep and superficial peroneal nerves innervate the muscles of the anterior compartment despite arising from the dorsal division of the lumbosacral plexus. In this frame, you can see the process. Medial rotation produces this arrangement in a similar fashion as we talked about regarding the thigh. Notice the position of the tibial innervated muscles here and here. This later arrangement corresponds to the adult muscle position. In the foot, rotation takes place in a similar fashion, but because of the feet position, plantar down and dorsal up, fibers from the dorsal division by way of the deep peroneal nerve end up innervating the extensor digitalis brevis. All other foot muscles in the plantar aspect of the foot, here in green, are innervated by fibers from the anterior division of the lumbosacral plexus. The dramatic miliar rotation of the lower limbs during the 6th to the 9th weeks causes the myotome to spiral. Hence, embryologically, posterior muscle groups end up anterior in the thigh and leg, and plantar in the foot. The rotation of the upper limb myotome is lateral, as indicated by the arrows, and more moderate. So, no such change in position of muscle compartments occurs. So the answer to this question is A. Next question. T1 innervates hand muscle but not the skin of the hand. A true, B false. Limb development starts as bulges corresponding to the cervical thoracic regions and the lumbosacral regions. The bulging advances, taking the appearance of limbs and ultimately looking like limbs, but in the process, the initially orderly straight dermatomal arrangement seen at the beginning of the limb development becomes disrupted. Notice that C7 is confined to the hand, but its equivalent in the foot, L5, is not confined to the foot. Also notice that C6 is lateral to C7, but in the foot, L4 is medial to L5. In this frame, I have illustrated the dermatomal arrangement of the adult leg and arm. I have now introduced a sketch of the leg and arm muscles. And now I am using colors to indicate the segmental innervation of the foot muscles. Notice that they coincide. S1 provides the lateral skin and muscle innervation, whereas L4 the medial. Now let's get our attention to the hand, where I have introduced coloring to the muscle matching those in the skin. Notice that they do not coincide. whereas the cutaneous innervation of the hand involves the 6th, 7th, and 8th cervical spinal segments. The muscles of the hand are innervated by fibers from C8 and T1 spinal segments. So the answer to this question is true. Next question. Which of the following movements is achieved by contraction of the muscles innervated by the superior gluteal nerve? A, B, C, D, or E? Please take a look at these figures and decide. In the next few minutes, we will talk about the muscles and nerves involved in these actions in the order presented in this question. Number 1. Abduction of the hip with the femur fixed or of the femur with the hip fixed is achieved mainly by contraction of the gluteus medius, here shown cut and here uncut, and contraction of the gluteus minimus. Innervation of these muscles is from the lumbosacral plexus by way of the superior gluteal nerve. Number 2. Internal rotation of the hip is produced by contraction of the gluteus medius, gluteus minimus, but also by a third muscle innervated by the superior gluteal nerve, the tensor of the fascia latae. Number 3. Extension of the hip is carried out by the gluteus maximus. This muscle is innervated from the lumbar sacral plexus via the inferior gluteal nerve. Other muscles that help with extension of the hip are the semimembranous and semitendinous muscle. These muscles form part of the hamstring muscles and are also innervated from the lumbar sacral plexus via fibers traveling in the tibial portion of the sciatic nerve in the thigh. Number 4. Flexion of the hip involves the iliopsoas muscle. The iliopsoas muscle has 3 components: psoas minor, psoas major, and iliacus. The innervation of these muscles is from the lumbosacral plexus by branch from the posterior division of L2, L3, and L4 before forming the femoral nerve, and by branches from the femoral nerve itself. Other muscles contributing to hip flexion, also innervated by the femoral nerve, are the pectineus, sartorius, and the rectus femoris. Number 5. Lateral or external rotation of the hip is carried out by primarily 6 muscles. One of them I drew its branch when we were building the diagram of the lumbosacral plexus, the piriform muscle that you can see represented here. The other external rotator of the hip we have already mentioned is the obturator externus, innervated by the obturator nerve. The other 4 hip extensor rotators are the gemellus superior, the obturator internus, the gemellus inferior, and the quadratus femoris. In this frame, I have placed an illustration of the posterior view of the pelvis. In it, you can see the attachment of the muscles just mentioned. All these muscles attach to the femur towards the posterior region of the greater trochanter of this bone. Other muscles that contribute to external rotation of the hip are gluteus maximus, sartorius, and the iliopsoas. So the answer to this question is A. Next question. Which of the following movements is achieved by contraction of the muscles innervated by the femoral nerve? A, B, C, or D? Please take a few seconds to look at these images and decide. The femoral nerve, as illustrated here, innervates the iliacus, the vastus lateralis, vastus intermedius, vastus medialis, and rectus femoris, before giving its terminal cutaneous sensory branch, the saphenous nerve. Contraction of the muscles just listed produce extension of the knee. So the answer to this question is A. Next question. Which of the following movement is achieved by contraction of the hamstring muscles? In this frame, you can see the hamstring muscles. The biceps femoris, as you can see, is lateral. This is a lateral view of the thigh, which I have introduced to show you the relation between the long and short heads of the biceps femoris. The long head is higher, the short head is lower. The innervation of these muscles goes through the peroneal arm of the sciatic nerve for the short head of the biceps femoris and through the tibial arm of the sciatic nerve for all other muscles. Contraction of these muscles produces knee flexion. So the answer to this question is B. Thank you very much for your attention.